Hello, everyone. Welcome to this special doctor dialogue. And you're seeing on the screen along with me 3 other faces, 2 of which you may know, and one you're about to know because I'm going to introduce everybody. And well, I'm going to introduce them, then they're going to introduce themselves further. We're calling today a doctor dialogue session, and it's on the science of compounding HRT, what you need to know. And there's a lot you need to know. In case you didn't know, there's a lot you need to know. So if you don't know, I'm Angela. I'm always here once a month, usually with Dr. Kat, Dr. Green. And today, one of Winona's very own head pharmacist. I'm not sure. Again, I think we talked about your title and I wasn't paying attention. So you're going to tell me in 2 seconds your official title. But this is Josh Gerhke. He works at one of our Winona pharmacies. And after Josh, I'm going to let Dr. Green and Dr. Kat introduce themselves. But in the meantime, Josh, take it away.
Hi, my name is Joshua Gerhke. I am a doctorate of pharmacy, and I work in both Twin Falls and Boise, Idaho. Did my very first compound when I was a teenager in 1996. So I've been doing hormones and compounding essentially my whole life, ever since I was a teenager. And I'm just the director of pharmacy for Winona, and I'm really blessed to be here, and I'm really excited to be able to share some of my knowledge that I've gained over the last 25 years.
Amazing. All right, Dr. Kat, go for it.
Sure. I'm Dr. Kat Brown. I'm one of the Winona doctors, and I'm now the new medical director of Winona as well. I take care of our patients in Pennsylvania, Florida, Michigan, and Hawaii as well. I'm a native of Philadelphia, also an Army veteran, have dedicated my entire life to women's health, and I'm a board certified OBGYN, and happy to be here and answer your questions.
So
Dr.
I'm Mike
Green.
I am the Chief Medical Officer of Winona. I'm also OBGYN, and in more states than I can count, because more than I have fingers. So I also maybe your prescribing physician, and really excited to have Joshua here. He's been with us since the very beginning. I can tell you that I have learned an amazing amount from him. He's like a really smart guy, and I have gotten a great education from him. He's also a super nice guy. I feel like we've become personal friends over the years of our Winona adventure, and so I'm really excited to have him here and educate you and share some of the knowledge. So basically the format tonight, I'm going to ask some questions. I think Angela's got a couple questions, and then we're going to open it up for you guys as well. So if you want to start typing questions in, you certainly can. If the questions come up as we talk, type them in. But go ahead and type the questions into the chat. Was it the question thing? Angela, what's the right instructions for that?
Yes, I just put them in the chat. So everybody, pretty much what Dr. Green just said. If you have questions, today we'd really like it if you could. It's not that we won't answer your questions if they're not about HRT specifically, of course. However, since we are with the experts today talking about HRT, it would be amazing if you had an HRT question for us. But of course, if you have a general perimenopause, menopause, reproductive question, you can certainly ask that as well. But we are going to have a bit of a conversation first, as opposed to jumping right into your questions. So just know that if you're putting them in the chat, we're not ignoring you. We're going to have the dialogue first, and then we're going to get to the questions. So I'm going to be checking those out while everybody's talking, and we'll let you know when we're going to open it up for that Q&A portion. So Dr. Green, take it away.
All right. So Joshua, let's start off with the easy. Why don't you give us an overview of compounding? What does that mean, and really, what is it?
Yeah, great question. So compounding in the traditional sense, or at least currently, is the practice of essentially taking two or more raw ingredients, and combining them, mixing them together to tailor to the needs of an individual patient. This can be done by a licensed pharmacist or a certified pharmacy technician under the supervision of a pharmacist. But back in the day, in the early 1900s, you would actually go to your pharmacy, and your pharmacist you would say, I have XYZ symptoms or XYZ disease state, whatever it might be. And your pharmacist would actually go back in the back and they would mix up, some pills, potions, creams, powders, whatever it might be, and actually customize that formula for you, and then give it to the patient. And nowadays, it's just a more scientific approach to it. We have a lot more high-tech instruments and some testing procedures, and obviously a vast amount of drugs to be able to treat a lot of different symptoms. So essentially, compounding in a nutshell is just providing a customized, tailored product for a patient for a specific need.
Great. So it's kind of like the old the apothecary at the Renaissance Fair, huh?
Absolutely. In fact, Lemp's Apothecary was the very first pharmacy I worked at. So it was in just one of your old time pharmacies, had a soda fountain and everything. It was great.
Oh wow.
Yeah.
That sounds cool. Yeah. So one of the big questions that we get a lot from patients is, is it true that compounded medications aren't FDA approved? And sort of what does that mean for the patient? How do they know this is okay? Is there somebody looking over your shoulder to making sure that things are done correctly?
Yeah, we actually get this question quite a bit in the pharmacy. One of the more common ones, because whenever you look at a compounded medication, there's this term that it's not FDA approved. And so traditional medications that come commercially available, ones you might get at your local Walgreens or CVS or local drugstore, that come from a manufacturer, they're approved for a particular condition. They've gone through some testing and some studies, and compounded medications are not regulated by the FDA, but the ingredients that are used to produce those products are FDA regulated. So all of Winona's treatments are formulated with ingredients that are sourced from an FDA registered facility. Those facilities are monitored, regulated, tested, inspected by FDA inspectors. But then once you combine the ingredients together, that's when the FDA considers them not a quote unquote approved product. Where we as compounding pharmacies are regulated by our individual state boards of pharmacies. And what I can say, being practicing in several states across the nation, many times the regulations from the State Board of Pharmacy actually have more strict regulations than the FDA, believe it or not. And so one advantage that we do have with Winona, because we ship to so many states across the nation, a majority of the states across the nation, we actually have to adhere to what we call the lowest or the highest strictest standards for that particular state, because if we do get when we do get inspected by that state, whichever one is the most strict, we just have to adhere to those standards. So we just make the highest standard our normal standard at Winona. So patients can always know that they have the highest quality product, and have some of the highest regulation and procedures for their customized compounded products.
Sorry, I was muted first. There was noise in the background, but that's a really good explanation. And I hope that makes everyone feel confident. My experience dealing with this is that, these state regulations are a headache, and they're hard to meet. And so I know you guys do a really good job doing that. Angela, I think your turn.
Yes, I'm ready. Okay, we've been being alerted that there are some people not able to get in, and I'm trying to put up.
Let's move on.
Wow,
you help them get in.
73 people.
It's okay. Let me ask this question to Dr. Kat. So one of the things that we hear a lot are warnings that compounded progesterone doesn't provide enough progesterone to protect the endometrium from uterine cancer. Can you say more about that, if that's true, not true, or what we should know about that?
Yeah, I think that you have to be careful, because there's a lot of products that are sold out there on the market. And in fact, I've had a lot of patients that go and they try to buy creams on Amazon or other sites, and they're buying topical progesterone. And those, I really have no idea what is in those. Really, the truth is progesterone is a larger molecule. And so the important thing is that we use micronized progesterone. that can actually go through the skin's barrier. And we use a dose that's safe and that we find is working great for our patients, and it's getting absorbed and protecting their endometrium. And the interesting thing is there's a lot of people out there in the media, there's a lot of social media doctors saying don't use topical progesterone. But actually, we've had topical progesterones and other forms of GYN medications for years. So it's interesting that suddenly everyone's so anti-topical form. But we've had, I don't know how many patients we're up to now, Dr. Green. I think you have better visibility of that than I do. But we track our patients' outcomes, and really, if I have a patient that's having any issues and ends up with any kind of development of a problem, we find out about it, and we have thousands of patients now, and lots of patients using the topical progesterone in our HRT cream and doing great and not having any issues with the overgrowth of their endometrium thus far that we know of. So I feel confident that it's doing what it needs to do. And that's what I talk to my patients about as well. It's just about the quality of the product that you're using and making sure it's the right type of progesterone that we know can transfer through the skin.
Thank you for sharing that. That's a very good answer. And I know lots of people have been asking, so hopefully it's shedding light on something that many people in the chat and people that write into us all the time are wanting to know about. So thank you.
You're welcome.
Back to you.
So, Joshua, I get this a lot. Why don't we offer compounded DHEA?
That's a great question. I want to just touch on one thing with that Dr. Brown had mentioned, and that was that the micronized progesterone. These molecules are larger molecules, and it's very difficult for them to absorb through the skin unless they are micronized. And so, if you are getting a product, from just some source, you don't know what it comes from, we want to really make sure that it's a micronized product. On that note, with topical DHEA, interestingly enough, DHEA it can absorb through the skin. There actually has been some studies to show that it can absorb through the skin. However, due to the chemical structure and nature of DHEA, it has very poor water solubility, which means that the way that we have to produce the product and incorporate it into our topical transdermal cream, we have to have such a high concentration that it just the actual product itself will not allow the DHEA to actually absorb through the skin. And so because of that, and because it requires such a higher dosage, we're not able to get enough DHEA in the cream in order to have pretty effective for an effective or have an effect on the body. And so we do require an oral formulation of that.
I remember when we were first starting and we were talking about what products we were going to offer. I said, man, we should just put everything in one cream. The estrogen, the progesterone, the DHEA, have the wonder cream, it'll be awesome. And you said, no, we can't do that because the DHEA won't work. And I'm like, well, other people offer DHEA, and you're like, yeah, they do. And it's basically a placebo. And it's that's not something we're going to do at Winona. We're not going to tell you this thing's going to work, and we know it doesn't work. So, I appreciate that you educated me on that really early. And, we want to make sure that everything we provide is number one, safe, and number two, effective. And we're not going to play games like that where it's DHEA in name only or something just to push out a product. So, I appreciate that.
Okay, we have a question. Dr. Green, I have a question for you. Still people can't get in. It's saying our event is full. I do not know how to get people onto this event. I don't know why it's saying it's full. We have plenty of room for people who would like to join, but we're going to keep trying. In the meantime, my question is, and I hear this a lot, people ask me this, and I'm curious myself. People come to us and say, well, I can get DHEA at Costco or Walgreens or wherever you buy your over-the-counter supplements or vitamins. So why should I come to Winona and get DHEA from you when I can get it cheaper and in bulk someplace else?
So 2 important reasons. The first one has to do with the quality of the DHEA. So DHEA is considered a supplement rather than a pharmaceutical by the FDA, which means it's not under the same type of regulations as other medications. So people can put almost anything they want in their pill and call it DHEA and get away with it. And unfortunately, people do. We are, it's kind of cool. We've gotten to the point where we are literally ordering millions of DHEA capsules at a time. And so when you have that kind of an order going in, you have a lot of control over the manufacturing. We've got people basically just making this specifically for us. And we're really picky and particular about what they provide. In fact, there have been batches of DHEA that have been rejected because they didn't meet our standards. And so, when you're getting Winona DHEA, that you're getting DHEA and you're getting it in the dose that we say, and that it's pure and it works and it's good. Again, it's why we don't offer DHEA cream. That may or may not be true from other sources. And so that's really probably the most important number one issue. The other thing that I've told patients before is that if you order DHEA on Amazon, you get DHEA from Amazon. And if you have a question about, gee, I'm having a side effect, or should I increase the dose, or should I decrease the dose? I don't think Amazon's going to help you much with that. But when you order DHEA from Winona, you get a board certified physician that you have access to 24/7, so that if you do have questions or a side effect comes up or you have problems, that DHEA comes with the expert advice of a personal doctor. So that's another advantage of getting your DHEA from Winona. So two important reasons, really: safety and quality issue, but also the advantage of having somebody help you, guide you through the therapy. So I think I'm up. So it's like Angela's disappeared for a minute. I know she had some cats in the background. I don't know if that's what's going on, but I was on a call yesterday with somebody, and their cats were fighting in the background, and then she went to break the cat fight up. I'm like, oh, was it entertaining?
Yeah, that's exactly what was happening. I had a full rumble off to the side, and I was like, oh, things are going to get broken. Pause. Sorry for that, everyone. Lifetime cat fest over here.
I got it right. Okay, so I'm up with a question. Let's see. I'm looking over here to see my questions from what it is. Oh, yes. So, Joshua, I've had patients that have decided to go to a local compounding pharmacy. And so they tell them, this is a dose of medicine that we've been getting from Winona, and the compounding pharmacy makes it for them. And maybe they're getting it cheaper or whatever. And then they come back after a couple months and say, hey, that other one didn't work. How come? And it's a good question. So why would the same supposed milligram dosing from one compounding pharmacy work differently than another?
Yeah, it's a really great question. And it actually is going to lead us maybe into like a little bit of we'll call it the inner
internet
working.
Connection lost. He's trying to reconnect. Uh-oh.
Oh.
I'm getting a thing saying his internet connection might be lost.
Is that me?
Same.
I'm seeing everybody.
Oh, I'm on.
Joshua.
Can you hear me, Dr. Green?
Yeah, I can. Uh-oh.
Not me now. There we go. No, I have a little.
I was about to call 911. I thought you fell and couldn't get up.
No, the laptop didn't want to hold up. Now, Angela's frozen for me, and Josh is showing internet connection lost.
Okay, I see everyone. Can
Everyone
someone type in and say if they can see us?
Yeah, they say they can see us, hear us. Okay.
Perfect.
I can't see Josh. Josh, can you hear or see us at all?
I'm good. I can hear you guys.
Put in the
I
chat
can hear you guys. I hear
if you
Dr.
can
Green.
see
I
us,
hear
Josh,
Kat.
and hear us, please.
Yeah, I'm good.
The chat is off to your right side, just in case you don't know.
Can you hear me?
Yeah.
Angela?
You good?
I can hear you.
Okay, he's good.
All right.
Chat.
Yeah, he's good.
We'll go ahead and continue. No problem. So it's going to give us
everybody's good.
Give our
so Dr. Green, but is he? I can't hear him if he's responding.
He's talking. I'll let you know if he stops.
Okay.
So going back to the question of why maybe any compounded product might not work from toothpaste, or not necessarily work, but maybe work either more or less effective. I know it's going to give a little bit of inner workings into our own Winona pharmacy. So a compounding pharmacy is, there is going to be some variability between pharmacies depending upon what their recipe is. Every compound is a recipe, much like a recipe for a cookie or a pizza or whatever it might be. There might be a little bit of nuances from one to another. And so a really good example, when we're making our products, we actually incorporate the raw powders, the progesterone or the estrogen or the combination of them into what's called an unguator. And think of it like a fancy blender. It essentially will it's got a blade in it. It'll mix up the cream into your individualized formulation. But depending upon what pharmacy you go to, you might get one pharmacy that'll mix it for 5 minutes, you might get one pharmacy mix it for 1 minute, and that can actually affect the density of the creams. One thing that Winona, our Winona pharmacies have invested in is called a planetary mixer, or a macerator is what it's called. And essentially what it does is it mixes the creams, it spins one way while the tub spins the opposite way. And what that does is it creates a vortex within the container itself. That not only creates a more homogeneous mixture, but it actually creates density in the cream, so that you can be sure that each and every time you get your Winona product, it's going to have the same consistency each and every time. And you won't necessarily get that if you hop from one pharmacy, one compounding pharmacy to another. And even within that, if that pharmacy hasn't invested in some of those, higher tech, more expensive machines and equipment, you will get some natural variability in it. And so we always say from my compound experiences, when you find your pharmacy that you like, stick with them.
So it sounds like there's a bit of an art involved in this.
Compounding it definitely has a lot of science behind it, but there is some nuances, and it really just takes knowledge and just having that background and having the experience to be able to navigate those potential differences.
Cool. I got to come see the, what's the fancy name for that thing?
Macerator.
Macerator.
Yeah, we call it the Maserati.
Cool. I was going to say, does your Macerator do 185?
Yeah. Planetary mixer, I guess, is technically the term for it, but yeah.
All right. So how do we know that the dose of the medication in the compounded cream is what's on the label?
Yeah, that's another great question. So going back to the regulatory boards, although our pharmacy, company pharmacies are not regulated by the FDA, they're regulated by the each individual state boards of pharmacies. There is another third party nationally recognized agency called USP, which is the United States Pharmacopoeia, and it's a regulatory board. And essentially, what it's tasked with is to make sure that all compounding and manufacturing of any medication, whether it be a medication from a big nationally recognized pharmaceutical company, all the way down to maybe your mom and pop local compounding pharmacy. They set standards, and those are both recognized by not only the FDA, but the individual state boards of pharmacies. And that's where you get a little bit of the harmony from a regulation perspective. They're very strict standards. And so we have to adhere to those. Again, going back to, we have to adhere to the highest level of regulation from the Board of Pharmacy in the nation, because we're shipping to multiple states. In addition to that, we actually we're required by law to have third-party testing on our products. So we send those out for batch testing. They're nationally recognized organizations, recognized by USP, sometimes by the FDA. We don't necessarily just use one third party. We use multiple testing facilities in order to just make sure that we're covered from our scents. Those testing facilities will test for densities. They'll test for the most important thing is, what's the concentration of your product that you're stating, and does it actually contain the ingredients that you state that they are? That's their main focus. And then as a secondary focus for pharmacy, they'll test them to ensure that there's not any, foreign entities or anything like that in our formulations. So the combination of those, the regulatory sense with the third-party testing, we also, like many pharmacies, we have our own internal policies and procedures and processes to be able to ensure that we're getting that consistent product each and every time.
How much variation is there from batch to batch?
So with the nationally recognized standard per USP, well, maybe not per USP, but the nationally recognized standard is a plus or minus 10% variability. So if I was going to say this has 100 units of something in it, it could contain anywhere from 90 to 110. That's the national standard. At Winona, we have a more strict standard. We will only accept a plus or minus 5% variability. However, our internal standard practice is a very small 2%. So we aim for the 2%, and if we don't get that, then we'll generally reject that batch of product and just go back and restart. And so why this is important? If I have any members of the audience that have ever taken any medications like levothyroxine or Synthroid. A lot of times you'll go to your doctor, your provider, and they'll say, if you're on thyroid, stick to this particular brand of medication. You don't want to, even though it's maybe 100 micrograms, if you switch to another brand within the United States, there's a possibility that could vary by 10% because the nationally recognized standard is 10%. Again, going back at Winona, we want to make sure that we're stricter than that. So we adhere to that, 2% or 5% preferred, but 2% is our ideal. And so, again, all those different things that we do, we have the internal standards, we have our mixing processes, we do our third-party testing, can ensure that each batch is not going to vary very much.
Awesome. Angela, we should have called this Joshua Gerhke on the hot seat. So
Yes.
They're throwing them at me.
Let's let the audience take a shot at him.
Okay. Dr. Green, you're gonna have to tell me when he's answered the question because he's not on my screen and I can't hear him. I can only see you and Dr. Kat. So
okay,
I couldn't see him at all, but I hit my refresh button for the internet browser and then he came back.
Oh, maybe I should do that. Okay.
So you know that little spiral thing next to you? Yeah. Hit the refresh.
Hopefully it doesn't all go away. If I hit the toolbar like at the top, let's see.
It's going to dump you and then bring you back.
Okay. Hold,
all
please.
Right.
Should we see if there's some questions that we can
let's look
go through?
I'm gonna reboot.
Okay. So the first question I see, someone asked, is the age of 58, soon to be 59, too old to start HRT? And the answer is no. It all depends on your symptoms and really, if your symptoms are bothersome enough that they're affecting your day-to-day, it's not too late. We kind of have a magic age of 60 where we feel like it's safest for patients to start HRT before they get to age 60, because after age 60, you can be at higher risk for cardiovascular events if you start HRT, but 58 is not too late. So if you want to try to see if you're a good candidate, you can certainly go to bywinona.com and go through our onboarding questionnaire. For those of you that maybe have not checked out the website, it's a pretty easy process. You just go to the website, you pick which state you live in. If we are in your state, it'll take you through an adaptive questionnaire to ask you about some medical history questions, things that are pertinent for Dr. Green and the other doctors and I to know. And then we'll go through that whole process of kind of finding out what your symptom profile is. And if you're a good candidate, your chart will then get sent to one of our Winona doctors to review. And so then you can get a prescription.
By the way, I just saw, I don't know if you saw this article. I saw it yesterday or the day before, where somebody was making the case for starting HRT over 65. It's not something I'm willing to do yet, but the pendulum is definitely swinging. And they had a funny quote. They said, when someone asked them when they should stop HRT, they said, when you die. So, like, why be miserable?
Well,
So,
I have certainly heard colleagues and friends of mine, like, the female OBGYN doctor community, a lot of these women say, you're going to have to pry my HRT out of my cold, dead hands,
Yeah, and I think the pendulum is definitely swinging that way as more and more data comes out that it's really very safe.
That's
all right, Angela, back to moderation.
Here we go. Gosh, I can see you and I can hear you. Wow, that's
yay!
Great. We're gonna reboot. Everybody needs a reboot. If you're having problems, just plug yourself back in. Apparently, there's like 60 people trying to get into this webinar, and like it's saying our webinar is full. And I just checked all of our settings. It's not full. Thanks, Mercury retrograde. I don't know, but here we go. Yeah. Well, we'll
have to let them know that it's recorded and they can watch it later, right?
That's right. It is, exactly. Okay, so we have a good question from Stephanie who wants, I don't know who wants to take this. First to answer gets it. Maybe Josh, you want to hop in? Stephanie is asking, how much can we expect DHEA to increase female testosterone levels? Is that individual to our genetics?
That's a great question. Dr. Green, are you comfortable fielding that question?
Yeah, I can take that.
Yeah.
So it really depends. So obviously we don't do there's no genetic test to tell us, but I mean, any medication can vary from person to person. And any medication we dose, whether it's HRT, even antibiotics or high blood pressure medicine, there is a bit of a trial and error to figure out what's the right dose for your individual situation. And the right way to know that is generally we start on a dose that's about right. I like to aim a little bit low because I'd rather not quite get all your symptoms and cause side effects, and then titrate up. We know that DHEA is a medicine that's used in the bodybuilding community, or a supplement that's used in the bodybuilding community to provide testosterone. In really massive doses, it can provide bodybuilder levels of testosterone. So that's not what we're after, so we don't do that. We're really looking to try and get you into sort of normal female range. And we found that 25 to 50 milligrams is an effective dose for most patients. At Winona, we don't prescribe higher than 50 milligrams because our experience has been that once you get over 50 milligrams, the side effects really become a giant problem. And so the risk benefit is just not there. But at 25 to 50 milligrams, it's extremely safe. Occasionally you get some annoying side effects like, acne and those kind of things that, we can decrease the dose and treat. But we don't get the really bad, dangerous, irreversible side effects that you can see with really high doses of DHEA or testosterone. So safety is always our primary thing. And obviously efficacy, getting you feeling better. But DHEA works for a lot of our patients. And we generally start people on 25 and we'll go to 50 if needed. And that's really as high as I feel comfortable prescribing.
Okay. We have a good question. It's over here, not in the chat, but in the questions section. I just happened to notice that was lit up. So I scrolled over here and we have some additional questions. And one is, Wendy is saying she's never taken HRT. What alternative do you recommend? She says that she's 63 and heard that HRT is obviously not recommended to begin at that age. So alternatives.
What was the main question? Alternatives to the systemic HRT?
Yeah, to age
63, I guess. So
yeah. So I mean, for my patients over 60, I think one of the other things that can be really beneficial that we don't talk about enough is vaginal estrogen. So one of the big lifestyle changes that we notice with menopause is that when we lose estrogen from the vaginal tissues and those tissues that support the bladder, we start to get this what we call genitourinary syndrome of menopause. Where the skin gets thinner, we lose lubrication from the area, the vagina is less elastic, we lose the folds of the vagina or the rugae, so sex becomes more painful. And so sex is an important part of life, and I think just the general comfort in that area as well. Vaginal estrogen can do such good things for the tissues in that area, and it's very minimally absorbed systemically, so it's very safe. Even patients that have had histories of cancer can use sometimes vaginal estrogen as well, just because it's only topical in that region. So that would be a good option if you have symptoms in that region of your body that you'd like to improve upon.
Okay, we have a good question. I know we talked about this the other day, Dr. Green, and this came up. Jill is asking, Why did Winona choose the BiEst versus TriEst formulation? And 2, how can we access less progesterone in creams along with our estrogen? Oh, and there's a 3. We can come back to this and break it down. And then the third part is there an opportunity to add in testosterone to your cream formulation?
So let's go backwards because it's the easiest. Testosterone is a controlled substance. So we can't prescribe testosterone on our platform. It's just the law of the land. So people are always, when are you going to do testosterone? It's like, write your congressman. Basically it's going to take legislative change for us to be able to do that. Not that testosterone is not helpful. It's just not something that we can provide in this format. The DHEA works well to provide testosterone. And I think it's a great substitute for a lot of our patients. So that's kind of what we do with that. The progesterone question was sort of answered, but let me, there's a minimum amount of progesterone that needs to accompany the estrogen to keep this all safe. And as I said previously, safety is the number one thing. I mean, if I relieve your hot flashes, but I kill you, I haven't done you any favors. So we've got to keep this safe. So we've got to provide the minimum amount of progesterone to protect the endometrium, because estrogen is helpful to almost every tissue in the body, but the one place it causes problems is at the lining of the uterus. That inside lining is called the endometrium. And so it basically stimulates those tissues, and if unchecked, it can overstimulate, which can lead to a hyperplasia and eventually even a uterine cancer. And so when we add progesterone, it reverses that, and it keeps the estrogen from overstimulating the uterus. And actually, women that are on combination of appropriate dose estrogen and progesterone are at decreased risk of uterine cancer than women that are on nothing at all. So it works. The progesterone works really well, but you need enough of it. And so all our creams are formulated with that in mind. And so we keep the estrogen progesterone ratios, and Joshua, you can speak to this maybe, in a way that we know that there's a safe ratio there that's not going to cause problems. And so we really can't go lower on the progesterone because we've got to keep it safe. So that's the reason for the ratios. And it's we're sort of stuck with that because of the body's physiology. And so there's only sort of so much we can do and still keep it safe. I don't know if there's anything, Joshua, that you want to, since I was kind of talking about compounding and ratios.
Yeah, if it's okay, we might as well just do a double whammy, because somebody else had asked a question: why did we choose that combination of it's not related to progesterone, but our BiEst 50/50? Traditionally, compound pharmacies have chosen either a 50/50 ratio, that being 50% estriol and 50% estradiol. So if you're getting a 5 milligram dose, 2.5 milligrams of that would be each, versus an 80/20, which is 80% estriol and 20% estradiol. And there's varying theories out there as to why one is better than another. There's not a whole lot of good head-to-head studies. That is one of the troubles with compounding, is there's no big pharma money behind it. So there's not a lot of great studies out there to support an advantage of one over another. So we've chosen the 50/50 mainly because it's been kind of the tried and true. It's been the one that's been out the longest. Estriol is a little bit weaker estrogen. And so actually it's quite a bit weaker than estradiol. And so in order to get the results that we're looking for, we've just chosen that 50/50 ratio as just our standard. And then going, if you don't mind, Dr. Green, so going back to BiEst versus TriEst.
Yeah.
So TriEst is an interesting one. So, we talked about estriol as the weak estrogen. Estradiol is your middle of the road estrogen. And then you have E1 or estrone. That's the tri part of the TriEst. That was a very common practice, maybe, probably 15 or 20 years ago. And we've really sort of seen a prescribing change to just the BiEst. The main reasons are that during menopause, estrone is not only the most potent hormone, but it's the more dominant one that we have, or that women have, and so that way they've just shown there's just not really a need to supplement with the estrone, because those levels are already fairly high during menopause.
Excellent, thanks.
All right, we have a good question from Marcia. She says she's 49 and she switched from birth control pills to compounded HRT, DHEA, and progesterone pills at night. She feels better, but is no longer getting periods and that she's spotting. She wants to know if she should be on sequential HRT instead, or is it okay to no longer have periods while on HRT?
So the interesting thing about that is that because you were on birth control, the birth control pills were likely kind of forcing you to continue cycling. But if you're starting to have changes, this could be your body's own natural progression of the menopause transition. And so the spotting might be your new version of your periods. And the fundamental way birth control works is so different than HRT. You know, when we give you birth control, these are synthetic hormones that we're using to try to suppress your body's own natural hormones to try to prevent ovulation. Whereas when we give you HRT, we're trying to give you back, especially bioidentical HRT, trying to give you back the hormones your body is no longer making in adequate amounts. So it tends to do better for the symptoms of menopause and to help with your symptoms better. So I wouldn't worry so much about not having the full-blown periods. I mean, I personally would take that as a blessing to not have a heavy period anymore and have just spotting instead. But if the spotting becomes irregular or a problem, and you know it's becoming something that's a nuisance to you, you can certainly talk to your Winona doc, and we might need to make some adjustments to help improve that if need be. But it's okay if you're not having periods anymore.
Okay, good. Okay, this is a question for Dr. Green specifically. Mercy is saying she's 4 months into treatment with HRT, but her symptoms are not completely gone. I don't know what the question is. It's more of a statement, but maybe you want to talk about that.
So yeah, you know, the body's needs sometimes change. It is a menopause transition. And so what's going on is the ovaries become less and less efficient at making hormones. And it changes with time. And so the body's needs and how much replacement can also change. So sometimes we'll have people that are stable on a dose and doing really well for some amount of time, sometimes a few months, sometimes years even. And then all of a sudden the symptoms start coming back. And that's a sign, okay, well, your body's changed now and needs a little bit more hormone, and we need to adjust the hormone. So if you're finding that, you know, things are better than they were when you started, but they're still not where you want them to be, then I assume if you ask me, you must be my patient, send me a message so we can make some adjustments because there's no reason you shouldn't be feeling your best. And so adjustments to the medication, sometimes up or down, need to be made from time to time. That's a pretty normal thing.
Okay. We have another question. Oh, go ahead.
Just real quick, I just wanted to clarify something. Going back on the estrogen, I just didn't want to give any misinformation. So on the estrone levels, the E1, they are higher in menopause, but estrone is not a more potent. Estradiol is actually the most potent, the E2. So I just wanted to clarify that. So E1 and E3 are weaker. The estriol are weaker, but the estradiol is the most potent. But their estrone is found in the highest levels during menopause. Sorry about that.
No, you don't apologize. That's important information. Okay, this is maybe a good question though. The question is, and I think this is a good one for you. Are our ingredients sourced in the States or abroad?
Yeah, that's actually a very, very good question. So the reality of just the way that our healthcare system works, I would say 90% or greater of our raw ingredients, whether they are compounding pharmacy or major manufacturers, are developed in China and India. Those are the two major countries that produce these. And so I understand that sometimes there can be a little bit of unease or questioning what the standards are for that. But going back to the FDA thing, the FDA actually does travel abroad, and these are FDA registered facilities that are producing these products. And then when they get imported into the United States, many of those raw products are still retested a second time. And so although they may not be produced within the United States, they are still have third-party testing and are regulated by the FDA, both abroad and here. And so going back to that, Winona, we don't purchase any of our products directly from those facilities. We actually purchase from a third-party wholesaler that they actually have their own certificates of authenticity and then do their own testing on those products and provide us with those certificates of authenticity. And then if we need to request testing results, we can request those test results as well. And that's actually a requirement of most. I'm not aware of any state board of pharmacy that allows compounding pharmacy to purchase raw product or raw chemical from a non-FDA registered third-party wholesaler.
Let me just to be complete though, it's all put together in our facilities in either Idaho or California. So our pharmacists under Joshua's supervision, but the Winona pharmacy are taking these products and making the compounded product for you in either Twin Falls or in California.
And then again are retested once we produce those products again, just for safe measure.
Okay. Kimberly says, "Hi, Dr. Green. You are my prescribing doctor." And our biggest
I'm popular tonight.
You are.
Dr. Green in the house. The biggest concern with taking estrogen is the possibility of cancer. I need more insight on the subject. Okay, take it away.
Okay, so a couple things on that. First of all, estrogen's given a bad name about this. It's actually the progesterone that increases the risk of breast cancer, not the estrogen. So the interesting thing is there's several huge studies that looked at this, and women that are on estrogen only HRT, generally because they've had a hysterectomy, do not have an increased risk of breast cancer. It's women that are on combination estrogen and progesterone, and that increases is actually really small. Estrogen actually decreases the risk of several different types of cancer, colon cancer probably being the most important. But really for me, the big picture is the goal is to live as long and healthy a life as possible. And if you look at women who are, appropriate candidates for HRT, that are on HRT versus women that have never been on HRT, the women that are on HRT on average live longer, healthier lives than those that have never been on HRT. So, this is a bit morbid, but the one thing that everybody in the world can agree on, I think, is that everybody has to die at least once. So, eventually we're all going to, meet our maker, so to speak. The idea, again, is to put that off as long as possible, as long as you're living healthy. And HRT is going to help you do that. Whether you end up dying of, dying of old ages or a heart attack or a stroke or a cancer, something's going to get you someday, or a car, or a rock falling out of the sky. You just never know when it's your day. But eventually, we're all going to die of something. But if you're on HRT, you're more likely to put that off longer than if you aren't on HRT. And to me, that's kind of the big picture important point. But as far as specifically cancer goes, estrogen really isn't the boogeyman everyone makes it out to be, and it actually protective against several different cancers.
Okay, I have so many questions. I'm going to try to get through most of these, but there's a lot of questions here. Okay, Nicole says she is 6 weeks on the 50/50 cream and DHEA. She feels a million times better already. We love that. Her question is regarding melasma, and can the HRT increase the dark pigmentation? And if so, is there a way to combat that? She doesn't want to stop treatment because she feels so much better.
I think that one of the important things is melasma can be caused by any kind of hormonal treatment. Often we see patients that have a tendency toward developing that, get it with birth control even. And so generally we try to go with as low of a dose as possible, but there's not really a way to reverse the melasma once it starts developing. You could work with a dermatologist and do like skin lightening treatments on the areas where the melasma develops. But there's no way to completely prevent that if you're going to take hormonal treatment of any kind, just because it's one of the risks if you're prone to melasma developing.
Okay. Colleen, sorry, I skipped your question. Okay, she says, I'm taking, and I don't know if I'm going to pronounce this right, Junel Fe.
It's Junel Fe because it has iron added to it.
Is that an I? What is that? Okay.
That's right. I forgot what Junel Fe was. Good job.
What is that? Junel Fe. Okay, cool. It was a new drug I just made up for today. Got prescribed this prescribed estrogen, not birth control, and doesn't believe in HRT, and wants to know if, let's see, the BiEst 50/50 and DHEA 25 milligrams from Winona is enough for her to keep taking if she were to remove the Junel Fe.
Well, so, I mean, one of the important things I think that's important to talk about is that there's a lot of doctors out there that say they quote unquote don't believe in HRT, but HRT is so much safer than birth control. So, you know, Junel is a birth control. And so you're literally taking a birth control to try to suppress ovulation and suppress your ovaries rather than giving your body hormones that it needs to help optimal functioning. So I think that you might find that you might do better without it. Generally, in the OBGYN community, we usually recommend stopping birth control at age 50, just because the risks outweigh the benefits at that point, because your risk of pregnancy drops off dramatically. So depending on where you are and how old you are, it might not even be a good idea for you to still be taking birth control.
If you're on both and you stop the birth control, occasionally we need to increase the dose of the HRT. So that's something to keep an eye on, which isn't a big deal. You just let us know, and we can increase the dose for you. A lot of times you don't, but I have noticed that sometimes that can be sort of a secondary effect. But that's easy enough to take care of.
Okay, we have a good question here. Tammy wants to know, why do we not recommend progesterone for women without a uterus? And she's asking, isn't there other benefits to progesterone other than just protecting uterine lining?
Well, there's some people out there that'll say there's other benefits for it, but like Dr. Green mentioned earlier, that risk for breast cancer development is actually higher when you have combination estrogen and progesterone. So the primary benefit for the progesterone is to keep that uterine lining thin. Estrogen has such beneficial effects throughout our body, but in the one place that it does something bad is that it makes that lining of the uterus grow. So progesterone counterbalances that. So if you don't have a uterus, you really don't need that progesterone function to do that. So it really, everything in this world, no medication is without risk, but you really have to weigh the risks and benefits. So for the slight benefits you might get from taking progesterone without a uterus, is that worth the risk of the increased risk of breast cancer by taking the combination? That's what we have to weigh. And I do have some patients that choose to do that, but it's a conversation that you have to have with your doctor.
Okay. And
I would say the majority of patients do really well with estrogen only. Mm-hmm. So I always encourage you to try it. And then if it turns out it's not enough, we can always talk about adding progesterone down the line. But you might as well try and start with the least amount of medicine as possible and see how it helps you.
Right.
I think this covers Sheila's question, which was, why do you not recommend progesterone for women who've had a hysterectomy? Are there benefits without a uterus? So I think we're good on that. Okay. Kimberly says, what is in DHEA and what will it help me with? I don't want added weight gain, as this is the main thing I struggle with in menopause.
So the DHEA stands for dehydroepiandrosterone. It's a precursor hormone supplement that basically, when metabolized by your body, it breaks down into estrogen and testosterone. So it's a way for us to naturally increase your testosterone levels without giving you testosterone, since we mentioned earlier, testosterone is a controlled substance. So we can't prescribe it via telemedicine. In general, most patients, it actually does the opposite of weight gain. Usually it helps with weight loss. It helps with our muscle development. It helps with metabolism. It helps with fatigue and energy. Helps give people that boost that they need. So for most of our patients, it's a nice, helpful adjunct to the regular estrogen and progesterone HRT to kind of help boost the metabolism and help with weight loss as well.
Mm-hmm. I can personally vouch, when I don't take DHEA, there's like a good slump. So everybody, if I'm looking sleepy and so forth, it's usually because I've skipped DHEA for more days than I should have. So
And then, hey, Angela, since we're on that topic, Angie looks like she had a question as well. So can DHEA be made into estrogen in the body? Kind of that cascade that Dr. Brown was talking about. So DHEA naturally can convert down to testosterone, which can raise the testosterone levels, which is a good thing. But that testosterone can then be converted over into the various estrogens. So yes, the answer to the question is yes, it can. It's just a matter of the body's function of how much of that of how much testosterone will be produced from that DHEA, and then how much of that testosterone may or may not be converted over to an estrogen.
And I want to jump on that as well, because if you go on the Mayo Clinic website, they're going to, or the Cleveland Clinic, because they use the same ChatGPT engine to write the same articles, but that's a whole nother story. Anyway, they're going to warn you that it's dangerous to take DHEA and estrogen at the same time, because it may make your estrogen levels too high. And the issue is there are people taking massive doses of DHEA, and in those massive doses, yes, there's a substantial amount of estrogen that you get from the DHEA. But again, at the 25 to 50 milligram dose where we prescribe, it's really not an issue. Plus, we're the ones also prescribing your estrogen, so we can control it that way and make sure that you're not getting too much. It's interesting, in the bodybuilding community, these guys take these giant doses of DHEA, and then they take on top of that an estrogen blocker, so they don't get gynecomastia, which is basically they don't grow breasts from the DHEA. So it is an effect that can happen, but generally in the really high doses. Otherwise, the estrogen contribution is really pretty minimal. It's really just testosterone benefit that we're getting out of the DHEA. I just wanted to say that because I know that's out there on the internet.
That is a very good distinction to make, because people do come to us a lot with like, well, I read this article and it says whatever it is, XYZ. So thank you for debunking that. Okay, Melissa has a good question. She says, please explain how our bodies use a 50-50 cream in the way it's needed within our bodies, as in it won't use the excess if not needed, or the 50-50 is totally absorbed and changes our cycle. Do we understand the question? Yes, kind of. I mean, if you give too much of the cream, yeah, it's going to cause problems. There's in any medication, there's a sweet spot between the a dose that doesn't do anything and a dose that causes side effects. And I just blanked on the name, Joshua. The therapeutic window is what they call it. So the therapeutic window is that sweet spot where it actually works, and is the bottom, and the top of that is where it starts causing side effects. And sometimes that's narrow, and sometimes that's bigger. And so estrogen, if you give too much estrogen, your body's not just going to ignore the excess, it's going to cause problems. So we're really careful to dose it appropriately to give you just enough to get your symptoms under control, but not so much that it's going to cause side effects. And sometimes, honestly, we miss. And we've got to hopefully, again, as I said earlier, I'd rather underdose you a little bit and have to give you a little bit more, which is what we aim for. And I'd say the vast majority of my adjustments are adjusting up rather than down, because that's kind of the philosophy that we go for. But occasionally, it ends up being a little bit too high for you, and you get some side effects, and you let us know, and we say, okay, we need to decrease the dose down a bit. And then we find that sweet spot for you where it's actually taking care of your symptoms without causing problems. Okay. Jennifer wants to know, do estrogen patches and progesterone pills stop menstruation in perimenopause?
The answer is no. So, HRT generally is lower dose. It's not as effective in trying to regulate your period as, say, like other forms of treatments that we use for that in gynecology. So generally, we're not going to stop your pattern of menstruation when we start HRT. It might change it for the better. Like I've had some patients that say, their cycles are a little bit more regulated, a little bit lighter in flow, but it's not going to stop it when you're taking the medication.
Okay. The next question Tammy would like us to answer is, if estrogen is low, will DHEA make you feel worse?
No, it's not really related. And in fact, DHEA does contribute a little bit of estrogen. So if your estrogen levels are low again, it's the testosterone benefit that we're shooting for, but it will also provide some estrogen for you. So it shouldn't make you feel worse. It should still help. However, my experience is it's fairly unusual that DHEA by itself is going to be enough to really take care of all the symptoms of the menopause transition. It works, I think, really nice as an adjunct, as Dr. Kat was saying, to the traditional HRT, the estrogen and progesterone. But I found that by itself, it generally is not enough to really, get you over the symptoms of the menopause transition.
Okay. Do our estrogen pills contain any progesterone?
No. Yeah. Great question. So our oral formulations of estrogen and progesterone are commercial. We don't produce them. They're a commercially manufactured prescriptive product, and they're their respective products. So just estradiol oral tablets, and then just progesterone capsules. One thing to note about the progesterone capsules, though, is or the gel caps, they are in a peanut oil base, and so anybody who has any peanut allergy cannot take traditional progesterone capsules.
Mm-hmm. The nice thing is the workaround is the progesterone cream does not have peanuts. So if you have a peanut allergy, we can still take care of you. We just use the progesterone cream.
Wow. Is that all? Like, is that just at Winona that the capsules are made with that, or is that like traditionally across the board?
That's any commercially available progesterone is in peanut oil.
Is that because it's cheaper? Like, why is it made with peanut oil?
Yeah, I believe it has to do with the reason is that the original manufacturer of progesterone capsules is Prometrium is the brand name of it. That was just what their original formulation was, and I believe it was a combination of not only stability of the product, but also enhancing the absorbency of it as well. And so in order to produce a generic manufacturer, you have to produce exactly what the brand name manufacturer produced.
Wow. I'm learning all kinds of fun facts today. Yeah. That's a trivia question for anyone going to watch our Instagram tomorrow. What are those capsules made of? Yep. You have your answer.
So I do want to point out that when we use progesterone, we're talking about the bioidentical molecule progesterone. There are synthetic progestins, which is the word we use when they're not bioidentical. And there are progestin capsules or pills that aren't in peanut oil. The problem with these synthetic progestins is they tend to have a lot more side effects, particularly weight gain is particularly bad. Provera used to be the most common progestin used for HRT, and it's sort of classic for weight gain. In fact, there's a birth control option called Depo-Provera, which is an injection. And anyone who's used enough Depo, have had enough patients on Depo, know there's patients that show up for their second injection 50 pounds up, and you're like, oh, because it just really stimulates people's appetite. Megace is like the super example of that. And so that's one of the problems with these synthetic progestins is they have a lot more side effects, whereas the micronized progesterone doesn't really do that for most people, which is great.
Okay. All right. Next question. Anne says, before transitioning to Winona, her doctor prescribed estrogen gel and oral progesterone 100 milligrams. She switched to Winona cream, however, wants to know if it's still okay to take oral progesterone sometimes at night to help sleep, or is it too much?
It's not really particularly harmful for you to take too much progesterone, I think. If it's every once in a while, if you really feel the progesterone pill helps you sleep, you could certainly do that. Or if you prefer to take a progesterone pill and you want your medication separated out, we have that option too. So we could always do an estrogen cream, for your HRT, and then give you the progesterone pill if you prefer to take it that way. That might be a better option.
Ooh, Josh, we have a good question for you. Okay. Is it okay that I'm calling you Josh, by the way, or do you prefer Joshua? I'm sorry. Is it okay?
I go by both. Okay. I go by both. It's great.
It's like people call me Angie, and I'm like, well, don't call me that unless you want me to answer you. I don't mind it, but no one calls me that name. So sorry for just assuming
We're
Josh.
Good. Josh is great.
Hey, Josh. So the question from Jill is, can you split open DHEA and take half? assuming that it's okay with Dr. Green.
That's actually a very, very good question. And it does come up quite a bit actually in the pharmacy of, can I split this capsule open? It depends upon the capsule, of course. This particular DHEA doesn't have a special formulation that, from a sustained release or anything like that. So it's perfectly appropriate if you want to do that. Full disclosure, I personally have not tried that, and I don't know what the taste of the progesterone powder is. More often than not, the powders, call them the excipients, the inactive ingredients that are found, is the stuff that has to fill up that capsule in order to, make sure you have the right dosage. Typically doesn't taste very good. And so, if you really do want to lower that DHEA dose, and Dr. Green gives the blessing on that, or whoever your respective provider is, not a problem at all.
I have some patients that don't want to swallow the capsule, that have opened it up and put it on yogurt, and they tell me it's not bad. So I haven't tried it myself either, but I do have patients that do that, and they say it's not too bad. So
yogurt and applesauce are the pharmacist's best friend for children and adults whenever putting powders on.
That makes
peanut
sense.
butter if it's a dog, I guess.
Yep. Yep, there are some pills out there that taste pretty disgusting, though, so it's good to know that ours isn't disgusting. That's great. Good news, everyone. This just in. Okay. Lindsay's asking, can we ask for it? I'm assuming we mean the pills we were talking about that have the peanut oil. Can you ask for it to be suspended in olive oil if you're allergic to peanuts? So it's an option.
Yeah, that can be done at a compounding pharmacy. It's not a product that Winona offers, but in my experiences, that has been an option. But that's just not a product that we offer at Winona.
Okay. Lisa is saying she thought of using patches, but she goes to the thermal baths in Puerto Rico 3 or more days a week. Would it make the patches come off and stop working?
Potentially. So depends on when you apply the patch. As long as your skin is clean and dry without any kind of oil or cream on your skin, the adhesive should stick on your skin pretty well. But if you sweat a lot doing a thermal bath, and it potentially could make it peel up earlier than it needs to be. So that might be a better option for you to do the cream or to do the pill form.
I have had patients use like Tegaderm over their patch when they go.
Yeah.
So that's an option when they do something like that to protect it more. I'm not sure how well it really works, but I know that I have patients that do that.
Okay. We have a question about how many milligrams of estrogen and progesterone are in the cream.
Depends.
Yeah, we offer several products at Winona to be able to customize. The doctors and providers have an arsenal of varying combinations they can do for the patient. Dr. Green, I'll be honest, off the top of my head, I'm trying to blank on our combinations of the different types.
So we start at, I have a geriatric dog that's like senile, and he won't eat his food out of the bowl. I have to pick it up and his dry food and give it to him. So he was over here whining. So that's where I disappeared to. So it's kind of frustrating. Anyway, so we start at 1/100. So the first number is the milligram per ml of estrogen, and the bottom number is the milligram per ml of progesterone. Our typical dose is 2 pumps a day, which is 1/2 ml. So I'll let you do the math at home. But so we start with a 1/100 cream. Then we have a 3/150 cream. We have a 5/200 cream. We have a 7.5/200 cream. And this is kind of an interesting story. We had a 10/200 cream. The problem was we were just shoving too much medicine into the volume of cream, and the cream consistency wasn't good, and it was flaky, and people were complaining. So actually, Joshua did the math for this, and we came up with a 7/150 cream, 3 pumps a day, which is basically the equivalent of a 2 pump a day 10-200 cream, but it bypasses that problem of the cream consistency. So that's sort of our quote product line, and it really gives us enough variation that we can pretty much nail it in for almost any individual, and get it really honed in for what you need. So we can really individualize the approach based on your response.
Okay. So Delina, I'm over in the questions section, not in the chat, in case for those of you who are following along, follow along with me. Delina says she's taking DHEA and the BiEst cream with progesterone, and she's sensitive to all medications, and noticed that she felt and feels better from DHEA, but wonders if the cream is really working, and wants to know, does it take the full 3 months because of the absorption?
So my experience is the cream tends to take, on average, about 3 to 4 weeks to really get kind of a steady state drug level. So that's, some people get, it's kind of frustrating. Some people get this immediate benefit. I'm not really sure what's going on there in the first week or two. And then all of a sudden after like week 3 or 4 kind of goes away, and then it slowly comes back again, which I understand how that would be really frustrating. It's like you get a little taste of heaven and then it goes away, but it eventually does come back. The 3 months is when we really expect sort of maximum benefit. Most people start feeling benefit before that. But we like to wait that long. Really, we kind of have what we call a 10-week check-in before we adjust the dose. It's really, you know, the big reason is that if we adjust too early, you end up on a higher dose of medicine than you end up needing, which really increases risk and side effects. And so, like, the goal of any medicine is to be on the lowest dose necessary to solve your problems. So the 10-week or 3-month mark is kind of a, you know, if we're not there yet, then it's time to really rethink, and do we need to adjust the dose? But because you do expect sort of improvement up until that mark. But my experience on the creams, it takes about 3 to 4 weeks to really get that steady state. And sometimes people get some side effects at the beginning as their body is adjusting in those first few weeks. They tend to go away pretty quickly. But I think that's the majority reason why.
Okay. Tammy says she's 52 and is postmenopausal. She has 0 health issues and doesn't take any medication. However, she has menopause symptoms, and HRT interests her enough to be here. She's very concerned about HRT developing possible health issues, cardiovascular, cancer, etc., whether it's now or in the future. So it sounds like she's looking for reassurance that it's okay to take it, maybe?
Well, I think that you have to weigh the risks and benefits for yourself with any medication when it comes to that. But if you're specifically thinking about those issues with regard to HRT, you also should be thinking about the health issues that happen to us after menopause without intervention. So there are significant changes in a woman's body, and we are at higher risk for heart disease without HRT. The estrogen tends to be cardioprotective. We also become at higher risk for bone loss and osteopenia and osteoporosis as we age when we lose estrogen. So your bone health is going to get weaker as well. Not only that, but estrogen is really integral to the connections in our brain chemistry as well, neurotransmitters, the development of serotonin as well. And so we're finding that, you know, and there's different research articles to point either direction, but really most of the data that I've read really helps me to see that it's really protective against dementia. And it really helps for optimal brain functioning as well. So, you know, when you're thinking about the risks of a medication, think about what your risks to your health are without doing anything too. And you have to weigh the risks and benefits for yourself, because you are your own body and you have to take care of yourself.
Okay. Well, I don't want to skip that. We have a follow-up question here. Josephina had asked earlier, she had a question, but her follow-up question is, can someone who's had endometrial cancer stage 1, S/P, THEA, BSO, be on HRT?
So that's a complicated answer. I mean, actually it's not. The answer is yes and no. Maybe is really the key. At Winona, it's not something that we would prescribe. And really, we've taken a really conservative approach to this. And my feeling is that We do a really nice job, I think, with the constraints we have with telehealth. But it's different than sitting down in the office and having a half-hour conversation and looking and talking to your GYN oncologist and looking at all your records. And I think that something like that is pretty tricky and really is beyond what we should be doing with Winona. So depending on, there's other things, the grade of the cancer and tumor markers and things like that, that will go into this that are really fairly complex as to what your risk is. It's not really something that we would feel comfortable prescribing Winona. It doesn't mean that you're absolutely can't have it or shouldn't have it, but it's something I think that's going to take sort of a lot more discussion than we can really provide. So the answer is no, it's not something that we would provide at Winona. It may or may not be something that could be okay for you and would require kind of more conversation.
Okay. April would like to know, what are some of the known side effects that can come from taking too high of a dose of HRT?
I think what you can notice early on is sometimes your symptoms might get worse instead of better. So you'll have worsening hot flashes and night sweats instead of improving. Also for women, tend to notice breast tenderness, also some bloating and swelling as well. But the breast tenderness is my clue. So when a patient first starts on HRT, it can be normal to have some breast tenderness. And a lot of us have experienced that throughout our lifetime, especially during the menstrual cycle, different times of the month. But generally they're temporary. It's a temporary phenomenon. But if it continues and the breast tenderness is just not getting better, then that's a sign that the estrogen dose is a little too high and we might need to dial you back.
Here's an interesting question. Michelle says, although it's most convenient to use HRT continuously, she's heard and read that continuous hormone delivery can lead to estrogen and progesterone receptor fatigue, causing subsequent breakthrough bleeding. And she's experienced that herself and wants to know if you suggest a few days off occasionally to avoid that.
My answer is absolutely not. And now let me unpackage that. The first thing I ask people when they tell me that they're having breakthrough bleeding or they're having abnormal bleeding is, have you missed any doses of your HRT recently? Because missing doses of HRT, or as you put it, taking a break from them, often causes bleeding. So this is going to actually cause the opposite of what you're looking for. The withdrawal, particularly of the progesterone, is a signal to your body to shed any endometrial tissue, any of the uterine lining that's there, which causes bleeding. So taking a break for a couple of days is much more likely to give you bleeding than staying on continuously. This idea of receptor fatigue is an interesting one. It gets thrown around a lot. I don't know if you have I haven't seen any hard data that really backs this idea up. I know that people talk about this, but I haven't seen really any good scientific data that is true. It doesn't really make a lot of sense to me physiologically, but I know that people do talk about this.
The only receptors I ever worry about are Pitocin receptors.
Yeah, right. And honestly, let me back on that because we both have experienced this. So, and this, I'm going to digress for a minute. In obstetrics, we use a medicine called Pitocin, which stimulates uterine contractions. And when we get people on a huge amount of Pitocin for a very long period of time, there is a trick where we half the Pitocin and then work back up, and that sometimes helps. But that's an overwhelming amount of medicine that's flooding the receptors, and that's a lot different than what we're doing with HRT. So I guess receptor fatigue can be a thing, but it's really overwhelming the receptors with overbathing it basically with medication, and we're not doing that with HRT. The idea of continuous versus cyclical HRT really became popular about 15 to 20 years ago when this data came out that estrogen-only HRT does not increase breast cancer, but estrogen and progesterone does, which was really surprising. Actually, when the first study came out, I didn't believe it. My God, there's got to be some confounding thing. It doesn't make sense. And then another study and some really big, well-done studies back this up. And so it is true. And so what happened was people had this idea is, gee, maybe we should try and decrease the exposure to progesterone by using cyclic HRT. So the concept of cyclic HRT really wasn't so much to control menstruation, but to try and decrease progesterone exposure. It was a great idea, and people have tried it, and there's been sort of lots of different recipes, so to speak, for this, using it 10 days out of the month or 14 days out of the month. Some people even say 14 days every 3 months. There's all these different ways to cycle the progesterone in the HRT. Recent studies have come out and pretty strongly shown that it doesn't provide the benefit we were hoping for, and it causes more side effects. And so the sort of standard of care now, and the gold standard, is that continuous HRT is just as safe, if not more safe, than cyclic HRT, and has less side effects, specifically bleeding side effects. So you're less likely to have breakthrough bleeding and abnormal bleeding on continuous HRT than you are on cyclic. That's what the studies show. Of course, each individual mileage may vary because everybody's different, and so you may have had experience that's different than the average experience, which certainly happens. There's always outliers one way or the other, but that's why we use, with some exceptions, we use continuous HRT at Winona.
Lindsay has a question about DHEA. She's been on 25 milligrams for a few months and doesn't notice any benefits, and wants to know if she should go up on the dosage.
Quite possibly going up to 50 milligrams would be a good thing to do. It's something that you should discuss with your Winona doc. But if you've been on 25 and it's, for a decent length of time and it's not helping your symptoms, then an adjustment certainly may make sense.
Okay, some of these questions we've already answered about testosterone. So if I'm not answering your question, it's because it's already been answered. Apologies. All right. Someone says they have a DHEA 30-day supply. They paid for a 90-day supply and have almost run out, and they want to know if they will receive the rest of their prescription before they run out.
That one, Dr. Green.
Go for it.
So going back to Dr. Green's comment that we have very strict standards here at Winona, and so part of this called the short squeeze was that we did have to reject a batch of our DHEA, and so because of that we were awaiting our new shipment, and so we had to short fill those prescriptions, and so we're working through those. And you can imagine we have thousands of patients and are doing millions of capsules of DHEA, and so we're working through those. And correct me if I'm wrong, Dr. Green, we're generally shipping these. We're trying to ship those extra ones out at least 7 days prior. If you're getting down to just a few days left, they can go through customer service? Is that right, Dr. Green? That's right.
Yeah, message patient services, or if you can always message your doctor as well. We're basically just going to forward that to patient services because they're the ones that'll help you. So you cut out the middleman and message our patient service. These gals are amazing. So yeah, we have an unbelievable. I have several doctors that work for other companies, and they're always raving about our patient service department. I just had one today telling me how great it is compared to another telehealth company she works for. So message the patient service department, and if you're running low and it hasn't shown up yet, and they can help you and make sure that we get that medicine. But yeah, we're doing. You absolutely should get that before you run out. Just without asking, it should just show up.
Yes, it should. Mine does, like clockwork.
And just so you know, by the way, my wife also got 30. So we don't pick favorites. But I know she'll get the rest before she runs out.
Yep. Okay. I know we've been on here for a while. Is everybody cool to keep answering more questions? Anyone need help?
Yeah, and I've got one that may have gotten lost in the mix, Angela. I was hoping to address. It's one of my favorite ones. It looks like it came from Kimberly Smith, and hopefully Kimberly was still here. But to clarify, DHEA breaks down into progesterone and testosterone ? If so, what amount of progesterone? I really love this question. I'm actually going to put a link into our chat right there. And it's my favorite hormone picture. It's very basic, but it provides a really great picture of all the different types of hormones. And so when we're explaining things to patients, so you can see it from that. So when you take DHEA, it's going to naturally cascade down into testosterone, and then you can also see the andro, and then it goes down to testosterone, and then from there you can see testosterone can naturally go over into estradiol, which they can then go into your other estrogens. So DHEA does not actually does not naturally convert into progesterone. So progesterone is a wholly separate part of that natural hormone cascade. So it's a really great question.
I love that. I love algorithms and I love visual learning. So
I've seen a lot of these, and that's the best one I've seen.
Yeah.
Oh, it's great for the visual learner.
Yeah. And the side note to that, it kind of goes, it's not necessarily hormone related. It's more of a holistic method. But, when we talk about hormones, if somebody has a very stressful life and they're burning through their cortisol, it essentially is, if you look at that hormone cascade, your body's going to want more, quote unquote, want more cortisol because you're burning through it because of so much stress. So it's going to naturally rob your body of some of those of progesterone because it's going to need to be able to convert over to that. So, part of the lifestyle adjustment, in addition to balancing our hormones, is lifestyle change and reducing stressors in our lives. Easier said than done.
A couple more questions. We have a good question about migraines. Someone's asking if HRT has any impact on chronic migraines, for better or worse.
And some patients that have menstrual triggered migraines, just from the roller coaster nature that our female hormones are released, I think that HRT, by stabilizing and giving you a steady state, can actually help. And so that's something, every woman is a little bit different. I think headaches are pretty common for women to start developing in perimenopause just from all the hormonal fluctuations, myself included. One of my first symptoms that clued me into the fact that I was going through this was migraines all of a sudden, which I never had before in my life. So I think for a lot of patients, it can get better. The one thing I always kind of talk to patients about that have a migraine history, though, I always am curious if they have an aura with their migraine. Just because an aura, which is like sometimes a taste or a visual cue or a symptom that you can get that kind of prompts you to know a migraine is coming. It's like an anticipatory symptom. When women have an aura before migraines, it can put them at higher risk for having other side effects and medical problems when taking hormones, but typically more so with birth control pills, not necessarily HRT. But that's something that I always kind of talk to patients about when they have a strong migraine history, or if I see in their med list that they have like 3 or more migraine medications listed, I start to have that conversation with them.
For women with migraine with aura, birth control pills, combination birth controls are contraindicated. You shouldn't take them, but that's not necessarily true with HRT, particularly the transdermal. So you'd would want to go with the patch or the cream rather than the pill. But doesn't have the same contraindication as birth control pills.
I keep seeing your
dog. But it's definitely worth a
by.
discussion.
I know.
Your little dog walk by, Dr. Green.
My poor little dog, he's deaf and he's blind, but he's such a sweetie. He doesn't seem to know where he is half the time.
Oh my gosh. He should hang out with my 20-year-old cat she's turning 20 on Saturday, and she's like halfway confused where she is most of the day. Like, poor thing. I think we have 2 questions left over here. Lisa is asking, she says she's not had a hysterectomy and wants to know if the progesterone is still going to give her full benefits.
If she's not had a hysterectomy, what is the question?
It says she's not had a hysterectomy, and is the progesterone still going to give her full benefits?
It's probably a progesterone cream question, maybe. But the answer is yes.
Yeah.
We're not sure what you're getting at, but the progesterone is particularly important if you still have your uterus. And if the question has to do with the progesterone cream, we kind of answered that at pretty length at the beginning. But let me assure you that the Winona creams, the progesterone is adequate to provide uterine protection. So you'll get the full benefit of the progesterone from the cream form if that's how you choose to get your HRT, even if you still have a uterus. I assume that's what the question is.
Yeah. Okay. two pretty easy last final questions. Melissa says, is it normal to start gaining weight when you start HRT?
I think it can be normal to see some water retention, some bloating. Also, it can affect your digestive transit time. So all those things kind of cumulatively can equate to a few pounds on the scale. I usually tell patients to stay away from the scale. First 2 to 3 weeks that you're starting a hormone treatment, I would recommend don't weigh yourself every day. Focus on your nutrition, focus on your sleep, trying to optimize your sleep, and really focus on how your symptoms are improving and responding rather than focusing on the scale so much in the beginning. The weight loss will come to those who wait. They will come.
That's what they say. Okay, final question. Kelly says she's been on meds for 2 weeks and wants to know if she will continue to have a menstrual cycle.
Well, it's hard to say without knowing more background, like how old you are and what your cycles are doing now. So if you were having cycles and you start HRT and your cycles either are delayed or you've skipped the period, it can be based on the timing of when you started the hormones. If you are not having cycles and you're on the meds, we're not going to restart or kickstart your menstrual cycle again if it's already stopped. So I guess we would need more information about you specifically, but you can certainly ask your doctor that on the platform as well.
Some women, some patients have some bleeding when they first start HRT. It'll throw off the first cycle or two. So don't be surprised or scared if that happens. But it typically goes back to whatever your normal is once you've been on it for a few cycles.
Okay, I think we've got through everything that's here. That's a miracle, everybody who stayed here. Thank you for staying. We still have 44 people here. I think we only lost about not quite half, but that's okay. We've been on here a long, long time. So for everyone who stuck it out, thank you. And for all the people who watch this in the replay, we're sorry that you had to wait for the replay, but it's worth it, I hope, for you if you're here watching it on the replay. Yay, thank you for joining us. And we don't know what happened, but we're sorry that you had to wait. So, but we're hoping you get all of your answers covered here. And come back and join us next month. Dr. Kat, Dr. Green, me, same bat channel. We are going to be here answering your questions. Well, they're going to be answering your questions. I'm going to be reading the questions. So it's the 4th Thursday of the month. For those of you, we are going to be doing that on May 30th, 4:30 PST. So if you want more of this and you have more questions that you didn't think of yet, or you want to bring more next month, come see us. We love having you. We're here for all of it. Thank you, Josh, for being here. How did it go for you? Do you feel okay? Wasn't you?
I was nervous as a Nelly, but I got through it, and I just appreciate everybody bearing with me and fumbling through my words every now and then. But great experience for me, and I'm blessed to be here, and I really appreciate appreciate all of our patients and our Winona community. It's just it's where I think we're right at 4 years this year since our first patient, and it's just been amazing. And I'm just blessed to be a part of the Winona team. Every day is amazing.
It's great working with you, Joshua. I've really enjoyed and learned so much from you.
And it was so nice to finally meet you in person in February.
Oh, yeah.
That was good. Yeah, excellent. Names and faces are always good. And yes, thank you for compounding all of our meds, my meds, everybody else who takes them here and who is yet to take them but will. Thank you. And we wouldn't have such great products without your amazing skills and your brain that knows how to do things with all of the cooperative components. None of us would be able to do that. So thank you for working your magic and helping us all to feel better. And again, thanks to Dr. Green, Dr. Kat, for doing all the things that they do for the Winona community. And if you aren't part of the community and you want to be, you can join us on our private Facebook group called Winona Women. It's literally just Winona Women. You type it in, go there. We'll admit you. You don't have to do anything special. Just be yourself. Come over. We would love to have you join us with like 14,000 other women who are in perimenopause and menopause. You can share your stories there. And join us next month. We can't wait to see you. Good night, everybody. Thank you for being here, and we will see you next month.
Good night.
Bye.
Right.